but here we are, and I'm glad you're all here. In this webinar format, I can't see any of you, only you can see us. On the bottom, if you have a question, if you use your mouse, you can see a Q&A bubble at the bottom. So just ask a question, and that will we'll try and answer that. I'm sure we'll be able to. There's also a chat function. So if you want to let me know that I have a fly in my hair or something, just let me know. Or you can wait 2 minutes and let the fly away. Many of you know me, but a couple or a few of you don't. My name is Will Harper. I am the founder of Harper Health. It's a practice that I founded about a little over 4 years ago. After being at the University of Chicago for over 20 years, I was really excited to create a practice that really has its focus on taking care of people individually, giving them the time and attention that they deserve. That's really the focus of our practice, and the current healthcare system doesn't really allow for that. So this was the path by which I could be the best doctor I could be for my patients. I am grateful that not just me, but there are other doctors who feel the same way about practicing medicine. So a year or so later, I added Dr. Daly, and then almost a year ago, I added Dr. Hidaka to the practice. And Dr. Hidaka also has a pedigree with Northwestern, as do I, and he's an amazing doctor. His patients love him, and really happy to have him on board, particularly because he's going to take the lead on presenting this information to you about COVID-19 and influenza. I learned a lot from Dan and his research, and I am sure you likewise are going to learn quite a bit about COVID-19 and the flu. And again, as I was listening, I had about 5 or 6 questions I wanted to ask Dan. So I've got my questions lined up for him, and I hope you do as well. So I'm going to throw it to Dan to talk about COVID-19 and influenza.
Thanks, Will. I appreciate everyone being on the call today. We're going to talk about COVID-19 and influenza in this upcoming cold season. So we see here schematics of the influenza virus and the SARS coronavirus 2 virion. They're both enveloped viruses, and they both have an RNA genome. The influenza virus you can see on the right there with the dark blue and light blue surface proteins. Those are the hemagglutinin and neuraminidase proteins that characterize our flu viruses. And on the SARS coronavirus 2 virion, which is in gray there with the red proteins coming off of it, that's the spike protein that everyone's talking about developing a vaccine to. That spike protein allows the virion to contact respiratory epithelial cells and infect hosts via the ACE2 receptor. So as I said before, there are actually four types of influenza viruses, but A and B are typically the viruses that affect humans. And influenza viruses are characterized by this hemagglutinin and neuraminidase protein. There's 18 different hemagglutinins and 11 different neuraminases. So it comes out to about 131 different strains of the flu that are out there and circulate. When we talk about the flu, we talk about the phenomenon of antigenic drift versus antigenic shift. So antigenic drift is a process in which there are small changes, point mutations in the hemagglutinin and neuraminidase proteins that allow for there to be different strains of similar H's and N's of different types of flu. That's why there's an annual flu vaccine, because there's antigenic drift that occurs on an annual basis, and we need to update which virus strains to inoculate the population with. There's also this antigenic shift, and that's when there's a major change in the hemagglutinin or neuraminidase protein, and that's when pandemics are caused, because there isn't a lot of cross immunity as occurs with antigenic drift when there is an antigenic shift. So pandemics are only caused by influenza virus type A, an antigenic shift. This shows the peak month of influenza activity over the last 40 years in the United States. And you see here that February takes the cake in terms of the month where there's been a peak number of flu cases. It's really any time between December and March, with a couple cases that occurred in November and December, or October and November. We talk about the influenza burden of disease. Influenza infects on average about 8% of the US population per year. For 2017 to 2018 flu season, there were between 9.3 and 45 million flu illnesses. It kills an average of about 37,000 people every year over the last decade. And there's been about 3.2 billion in direct medical costs and 8 billion in indirect medical costs that are attributed to the flu. This graph shows the number of influenza deaths over the last decade per year. So you can see that some years we have a relatively better season, like 2011, 2012, and some years we have worse seasons as far as mortality goes. With in 2017, 2018, 61,000 people are modeled to have died from influenza. This graph shows the number of fatalities due to influenza pandemics worldwide. And I think the thing that stands out here is the Spanish flu of 1918, 1919 killed 50 million people. There's probably a lot of reasons and advances in public health and medicine that made that number so high compared to more recent pandemics, the Asian flu in 1957, 1958, Hong Kong flu in 1968 to 69, and swine flu in 2009. To put it in perspective, we've just surpassed 1 million global deaths from COVID-19. So compared to pandemic 1917, 1918 flu, we're not nearly near the case number that occurred then. And there are about 37.8 million cases now of COVID in the world. This shows the estimated disease mortality rates of different pathogens. So you see here the 1918 flu caused 10% of those infected to perish. You see swine flu 2009, 2010, about 4.2%. They list coronavirus 2019 here as 3.4%, but it's probably lower than that. It's probably on the order of between 2 and 3%, just given the number of asymptomatic infections that are out there that will dilute the number. And then seasonal influenza is estimated to take about 0.1% of those infected and cause death. It's an order of magnitude of about 20 times worse, coronavirus 2019 versus the seasonal flu. So influenza and COVID-19 similarities. Both cause respiratory illness that ranges from asymptomatic to severe disease, including death, unfortunately, in both. They're predominantly spread by respiratory droplets, contact and fomites, although we're thinking that COVID-19 doesn't spread very efficiently via fomites. That was something that we were very concerned about early on once the pandemic started, but it's something that hasn't borne out to be a main method of transmission. There are similar mitigation strategies for both, hand washing, mask wearing, social distancing, and travel restrictions. The incubation period, so for influenza, that's 1 to 4 days until symptoms develop. And for COVID-19, it's typically 5 days from infection until symptoms develop. And it's worth noting that the shorter incubation period of the flu allows for it to spread much more rapidly. So the serial interval of cases for influenza is much less than for COVID-19, just based on the more prolonged incubation period. For COVID-19, people can be symptomatic as early as 2 days or as late as 14 days after infection, which is where that 14-day quarantine comes into effect when someone's been exposed to COVID-19. Contagiousness, so influenza is thought to be contagious 1 day prior to the onset of symptoms, and an individual is most infectious during days 1 through 3 of their illness, but remains infectious for about 7 days from the onset of symptoms. For COVID-19, it's about 2 days prior to the onset of symptoms, and you can remain infectious for up to 10 days from the onset of symptoms. COVID-19, we're learning, can be aerosolized or can be quote unquote airborne and spread through smaller droplets that remain in the air. And there's also super spreader events that have been described with COVID-19 that haven't occurred with influenza, or are not thought to be a primary means of transmission of influenza. The clinical syndrome, we talk about this ILI, which stands for influenza-like illness. So fever, cough, shortness of breath, fatigue, sore throat, runny or stuffy nose, muscle aches, body aches, headache, and some people have vomiting and diarrhea, although this is more common in children than in adults. And one difference in the influenza-like illness is that COVID-19, you can lose your taste or smell, which doesn't tend to occur with influenza. So who are the people that are at risk? So for both influenza and COVID-19, it's the elderly, those with chronic health conditions, pregnant women. There's a difference in influenza disproportionately affects severely young children. COVID-19 is not thought to disproportionately affect children. Influenza, one of the main methods of spread is through children and the very young. That's not thought to be the case with COVID-19. And then in COVID-19, you see children being at risk of this multi-system inflammatory syndrome in children, which is different than influenza where that doesn't occur. So this shows the flu versus COVID-19 death rate by age. And you can see here just how dramatically different the viruses are in terms of their lethal potential. So for influenza, those over 65 is a 0.83% mortality rate versus if you just look at 60 to 69, 3.6%, 70 to 79, 8%, and then 80 plus, 14.8% of people will die from COVID-19. Those are sobering numbers. You're certainly not dealing with the same pathogen when you look at a graph like this and the death rate from COVID-19 versus that of the flu. So complications are similar in both illnesses. You can get pneumonia, respiratory failure, meaning you need to be ventilated and put on a ventilator, acute respiratory distress syndrome, where there's massive inflammation and infection that occurs in the lungs, sepsis, cardiac injury, multiple organ failure, worsening of chronic medical conditions, inflammation of the heart, brain, or muscle tissues, and then secondary bacterial infections, often secondary pneumonia that can occur. For influenza, we know that those with asthma and chronic lung conditions are affected more significantly. That hasn't been proven to be the case for COVID yet, although we're suspicious. And then for COVID, you see blood clots in the veins and arteries in the lungs, heart, legs, and brain. There's a hypercoagulable state that appears to be at play in COVID. And we also see this multiple system inflammatory syndrome, both in children and in adults with COVID. So treatment for influenza, most people have heard of Tamiflu. So we have a number of antivirals that if they're started within 48 hours of symptoms, they can reduce the duration and severity of influenza. So Tamiflu is the one that's typically given when people are hospitalized. They generally get Tamiflu to reduce the complication rate or risk of influenza. But there's also Zanamivir, which is Relenza, Peramivir, which is Rapivab, Baloxavir, which is Xofluza. For COVID-19, there's Remdesivir that's been approved under emergency use authorization that prevents viral replication early in the onset of illness. But its drawback is that it's an IV medication, so you basically need to be hospitalized in order to get Remdesivir. And then we know that steroids, when given later in the course of COVID-19, significantly improve outcomes when there's this massive inflammatory response that's mounted by the host. So vaccines. For influenza, as I mentioned before, there's an annual influenza vaccine, and that's because of antigenic drift that occurs with small changes in the influenza virus from season to season. Typically, it's a quadrivalent vaccine, meaning it's against 4 different strains of influenza. There is a high dose that's available for those over age 65, and that's either triple the antigen load or they're adjuvanted with chemicals that stimulate a more robust immune response. And it's worth noting that only 45% of people got the flu vaccine last year, according to the CDC. So something that we're always trying to improve is the uptake of the vaccine in order to vaccinate the population against a severe influenza vaccine, especially this year with COVID-19 also circulating in the environment. For COVID-19, there are multiple candidate vaccines in phase 3 clinical trials. They've been shown to cause a robust immune response, but we don't know yet of their clinical efficacy. And those stage 3 trials are ongoing. So for example, the influenza vaccine, the egg-based influenza vaccine for 2020-2021 was an H1N1-like virus and an H3N2-like influenza A virus. And then you had the influenza B, Victoria lineage, and Yamagata lineage that were included in the vaccine. So I thought it would be interesting to look at what the reasons are that people don't get an influenza vaccine. So this is for the 2019-2020 flu season for select reasons. Major reasons are in blue and minor reasons are in navy blue. But essentially, you know, patients were concerned about side effects from the vaccine. Some people believe that flu vaccines don't work very well. Some people thought they were unlikely to get very sick from the flu. So when it comes to both illnesses, it's prevention, prevention, prevention. That's hand washing, it's mask wearing, it's social distancing, and then for influenza, it's influenza vaccination. I think we all feel like a broken record because we keep talking about these mitigation strategies, but they are the things that work the best is preventing yourself from even getting the disease in the first place. And in the fall, what will the strategy be when someone has an influenza-like illness? It'll be testing, testing, and more testing. So the only way we're going to know if someone's got influenza or COVID is to test them. We're lucky enough that we've purchased a reverse transcriptase PCR test that we'll have available to our patients. Will give us results within 35 minutes, and we'll be able to run COVID, influenza A and B, and respiratory syncytial virus on a single swab. Similarly, or in addition to that, we'll have an antigen test for COVID and influenza A and B that will give us results more rapidly. But it's important that we have access to this and our patient population will have access to this because it's really the only way that we're going to know what we're treating in the fall. So what is the outlook for fall? So in colder climates, there's going to be less chance for outdoor gatherings, especially with the holidays coming up. People are going to be indoors where it's harder to socially distance. There's the concern of this talk, how much of the influenza disease burden is going to be out there in addition to the COVID-19 burden, which appears to be ramping up in the United States. And then there's this COVID fatigue. I think we're all tired of hearing the mantra, mask wearing, hand washing, social distancing, but it only takes 1 or 2 slip-ups to get exposed to COVID. So the predominant way that we treat this is prevention. And then there's the risk of depression and anxiety, and I worry about this particularly in our geriatric population who are sheltering at home and isolating themselves to prevent themselves from getting ill with influenza or COVID. So I thought it would be interesting to look at what the flu season was like in the Southern Hemisphere. So this looks at Argentina and Australia, and you see that in 2020, they began to have the start of a flu season, but due to lockdowns and mitigation measures from March through April, there basically wasn't a flu season. You can see here from 2015 to 2019, the peak weekly flu cases, and it just dropped off dramatically for both Argentina and Australia. This shows a number of specimens positive for influenza in the Northern Hemisphere at the end of the 2019 season, and you see there's a dramatic drop-off when the mitigation measures were put in place. So much less influenza toward the end of the season than we would have had otherwise. And in the Southern Hemisphere, this again just reiterates the fact that there basically wasn't a flu season. It dramatically tailed off with the mitigation measures that were taken for COVID-19. And that's good news because that means that there's a lot that we can do to prevent a severe influenza season and a severe COVID season upcoming. So I thought that this in particular spoke to what the flu was like in the Southern Hemisphere or in the US once COVID-19 was declared a global pandemic. So it says in the US, new flu cases plummeted a few weeks after COVID-19 was declared a global pandemic. The 2019-2020 flu season, once headed to be among the worst in decades, ended 6 weeks early. So I think the mantra is prevention, prevention, prevention. And then if you are symptomatic, it's going to be test, test, test in the fall. And with that, we can take some questions about COVID-19 and the flu.
Yeah, so Dan put up our contact information, our emails, our website, phone number. You know, if you're at all interested in the practice or you know somebody for whom a practice like ours might be of interest, please just give them our contact information. And we're always happy to talk to folks about what we do and whether it's of value. There are a few questions, you know, one of them is about, you talked about a super spreader event, and I've heard that term used a lot. So can you talk a little bit about that and what that really means, and certainly how to avoid one?
So we know that in super spreader events, someone who's particularly infectious can spread it to a lot of different people at the same time. And it's kind of one of those, it probably has something to do with the host who's spreading it and those who are contracting it, and also the environment that they're in. So a lot of these super spreader events we've heard of when they were singing or talking or kind of transmitting a lot of virus at one single time. I don't know that we know the biology of why it occurs in certain individuals, and certain people are more prone to being super spreaders. I don't know, Will, if you had a comment on that.
Yeah, there was that way at the early phase of the pandemic, there was this lawyer from New York who, I think he spread it to like 150 different people. So he himself was a super spreader. So it wasn't necessarily a super spreader event. There was something unique about maybe his virus burden, the amount of virus that was, he was expressing, that just made him a super spreader. So don't be a super spreader. The other thing I want to emphasize, I think that you brought up, is just indoors versus outdoors. And, in an indoor enclosed environment, we talk about how COVID-19, the SARS-CoV-2 virus, can be transmitted in an aerosol. So what's the difference between an aerosol and a droplet? Well, someone sneezes and you can see stuff fly out of their face. Typically, if you're within 6 feet of them, you might breathe it in. That's a droplet, and so certainly, influenza and COVID-19 can be spread that way. An aerosol is something that can hover in the air for a long period of time. And, an example of that is cigarette smoke. You can smell that, if someone is smoking nearby and don't see the cigarette smoke, you can still smell it, or a perfume or a cologne. Those are aerosols, and in an aerosol, there can be really small particles of virus. And if you're in an indoor enclosed space, and if it's particularly small, and you have one person with COVID-19 who's aerosolizing virus, even if you're more than 6 feet away from them, if there's enough concentration of virus in the air, you can get infected. So imagine an enclosed space with 2 people with COVID or 3 people with COVID. All of a sudden now this virus aerosolized is potential for, a super spreader event. So we can't emphasize enough, like, enclosed environments are higher risk. That's why restaurants outside, I don't know what we're going to do for restaurants over the winter here in Chicago. I've begun to see tents set up that are outside, but they have tents with, walls in front and back, and it's still an enclosed environment. So it doesn't seem like that is a safer way to protect yourself. But certainly outside, particularly if there's a breeze blowing, the chances of a super spreader event is much less. So another question, are there different types of flu vaccines this year? Is the one at Osco Walgreens the same as we have at our office?
So there are different flu vaccines that are out there. In particular, the high dose. There's one, as I said, that's adjuvanted. So there's a chemical in there to stimulate the immune system. And I believe there's also one that has triple the inoculum. So it's in a different way supposed to stimulate the immune system. I'm not sure. I don't believe that they've been tried head to head. One difference this year is that the high dose flu vaccine is quadrivalent, meaning it's against 4 strains. Whereas in the past, it was only against 3. Will, I don't know if you can speak to, because you do some of the ordering for our flu vaccines.
Yeah, there are different, I do not do the ordering. Steph, our nurse practitioner, I want to give her credit because she is certainly our clinical manager and does an amazing job getting our supplies. But there are different manufacturers, but I think everyone has the same 4 antigens, right, Dan? So
Yeah,
it
I
might be
believe
a
so.
high dose, but it's the same 4 antigens. So if you get a flu shot from us or a flu shot from Walgreens or Osco, you might get a different manufacturer, but it won't be a different formulation of what's inside. And as Dan said, it's those 4 antigens, kind of rolling the dice and hoping that the flu season kind of matches with the vaccine that we give folks. But, I think a lot of people, and what the Southern Hemisphere has noted, might have a pretty quiet flu season because people are going to be inside a lot more, not going to be on public transportation, spreading the virus. So as Dan also mentioned, I remember last flu season was awful. I mean, it was really bad. And again, once COVID hit, had a handful more cases in March, but did not see much flu after that.
I should add that. So I think for the egg-based influenza vaccine, they're all the same, but there are influenza vaccines that are not egg-based, and so they might have slightly different strains.
Yeah. So another question, which I think is important to emphasize here, is there any way, if I get sick, to tell whether I have COVID or the flu? So how do I know? And corollary to that is, what do I do? What can I do?
Well, you reach out to us, I think, is the important thing, because this is what we're here for. But it's, as I said, it's testing, and more testing, because you can't really be certain that something is COVID or influenza just by symptoms alone. So it's going to be contact us, we get you tested, depending upon the results of that test, whether or not we need something that's more sensitive, like a PCR test, or we need to screen you for flu or respiratory syncytial virus to get, the root cause of your influenza-like illness is really, really important, and something that we'll be trying to do this fall. So
you mentioned treatment, and here's another question about treatment. Remdesivir is a treatment, you said, that's IV, that can be used early on in illness. Can't you just give me an IV and give it to me in a clinic? You guys have IVs, right? So, there's that question. And the second question is, what's up with the antibody treatment that our president got?
So to speak to the antibody treatment first, I don't believe that there's been published data that's been available or nothing that's been in peer-reviewed journals for us to make a conclusion on. And I don't believe it's been given to more than a couple hundred people. So it's still very much an experimental therapy. I can't really speak to what the decision was when the president ended up getting it. And then for remdesivir, it is something that is widely available in the hospitals. It's not something, unfortunately, that we can get our hands on at Harper Health and administer twice a day. Almost by definition, you want to treat people that are more sick or more at risk, and so the hospital population is appropriate to get remdesivir early in their course of illness.
Do you know, we hear all the time, phase 1, phase 2, phase 3 trial, and, I'm trying to remember those phases back from medical school. And do you remember what those different phases are?
So phase 1, I think, is purely for safety. So they give it just to make sure that the dose they're giving is safe. I believe in phase 2, they're potentially looking for some response, but also very heavy into how safe the product is. And then in phase 3, that's where they really get into efficacy. How well does the therapeutic work? So it's the early phases that are about safety and finding the proper dose, and then phase 3 and further trials to determine efficacy.
Yeah, I think phase 4 is post-marketing, like post-distribution. Like you see medications go on the market and then they go off because once you give it to a lot more people, they start seeing more side effects. And if you're on our email list, I can direct you to our website, and there's a blog post about the vaccines. And so these vaccines are in phase 3 trials, and they might be, I think the Moderna vaccine they're trying to recruit 30,000 volunteers. The Johnson & Johnson, they're recruiting, I think, 50,000 volunteers. 50,000, so they're looking to make billions of doses of this vaccine delivered all over the world to people from different ethnic groups, and it's just to us, a test of 30,000 people and just checking for safety. We as a team really feel strongly want to make sure that if we're giving a vaccine to somebody and we're recommending it, we want to make sure that it's something that's extraordinarily safe, because the last thing we want to do is give you something that is supposed to protect you and ends up harming you. So with regard to the vaccine, we have some guarded optimism about the vaccine. Don't think it's going to be available for mass distribution until sometime in mid-2021. That's when I think a vaccine might become available. And the other kind of point I want to make that is so important, that there's a lot of people who, the buzz and the talk about the Spanish flu being 50 million deaths and, COVID-19 only 1 million. So, what's the big deal? I think Dan's slide on the death rate, this is a serious illness, and it's something that we can actually do something about. We can actually prevent it through public health efforts, but this is something that we can do. So to encourage each one of us to do our part to help prevent the spread. I often say you can't tell by looking at somebody that they're going to have a fever tomorrow, and that's what the big deal is you could have lunch with a really good friend, and then the next day you hear that they're COVID positive, and all of a sudden you're infected too. So part of this is being mindful and protecting yourself. Dan, there's a question here about a person getting COVID-19 a second time. So I haven't. It seems to be a fairly. I haven't read much about it. Did you read much about it or see anything about it?
I've seen that it's occurred, and like we're talking about a case report. It's pretty infrequent that this has been reported, but I've seen that it is possible to get COVID-19 for a second time in certain individuals.
Yeah, it's interesting. The question is really about immunity. We don't know. We've only known about this virus for less than a year, and we're learning every day all sorts of things related to the SARS-CoV-2 virus. And when it comes to immunity, whether you get that immunity or whether you get that immunity from being ill with COVID-19, how long does that immunity last? And it's not clear. We believe that the immunity that develops is both what we call cellular immunity and antibody immunity. So antibodies are the tags that attach onto the virus and basically direct our immune system to attack the virus. So that's the antibodies, and the cellular immunity is a little bit more complex, but it's about recruiting sort of a bunch of soldiers to attack the virus as opposed to tagging them with a laser. So the cellular immunity isn't something that we can test for. Like, we can't draw a blood test to say that you have cellular immunity to SARS-CoV-2. We can draw antibodies to see if you've developed antibodies, and the presence of SARS-CoV-2 antibodies means that you've been exposed to the virus. It likely means that you're immune to the virus too, potentially for a second time. And so in our patients, when they come in for an annual physical, we're checking COVID-2 antibodies on everybody, hoping, crossing our fingers, that you may have had an asymptomatic illness, and then you could theoretically be protected. In the past few months, I've had no patient have the antibodies without, having had an illness beforehand that we were aware of. So we do the antibodies sort of as a screen, just to hope that, maybe we could tell you're immune. I've also, last week, checked antibodies on a patient who had confirmed COVID-19 about 2 months ago, 3 months ago, and he wanted to see if his antibodies were still present so he could donate his plasma. And he still had the antibodies. They were still there. So the concern is that over time, your immune system may diminish or decrease with regard to the protective immunity that an infection or a vaccine would provide. So I'll say one more thing about this, which is our influenza vaccine, we believe, lasts about 6 months, right? So we boost your immunity to these 4 antigens, and then hope in that 6-month period, if you get exposed, that immune system boost will protect you. And then that immunity, that boost, goes down. So if you get your flu shot too early in the season, you see, Walgreens and Osco advertising it in August. Well, 6 months, you're only entering the peak flu season, which is why we recommend the flu shots a little bit later. So that's the question with COVID-19. Like, how long does immunity last? And this guy who got infected twice, it's possible that, we're at this 6-month period similar to influenza where his immunity is waning and perhaps he's at risk of getting COVID-19 again. So we're still learning a lot. And one of my concerns is, right now, COVID-19 is not a seasonal illness because there isn't enough. It's like in this, pandemic, not seasonal. I mean, we saw a little bit of a dip in the summer, but now we're probably going to see it, and we're starting to see it in the Northern Hemisphere starting to take off again. That's natural for a new virus in the community. And so it's not yet seasonal. It may get to a point where it's seasonal after enough people have been exposed, and we might see, a combo COVID-19 flu vaccine that you get every fall. But we're not there, and we won't be for a few years yet. But that's something I see in the future. We've got a few more minutes. Dan, do you know much about the data, the research on masks? I mean, there's some pushback, masks are effective, are they not effective? Should we wear one? Which type? Do you know much about the mask literature?
I don't, to be frank. No, other than that, we're getting word from people who should know that masks are effective, like Dr. Fauci. But no, I don't know of any specific data in terms of the efficacy of masking.
So the thing that, we know is the healthcare workers wear masks when they take care of COVID-19 patients in the hospital. They wear this, what's called an N95 mask, which protects them for up to 95 to 98% of aerosols. And so these are folks that are in high COVID environments, and they work. They work really, really well. But a gaiter, one of those, you see the football coaches using these where they just kind of pull up this rag over their face and then they drop it down again. Those have been shown to not be effective in either protecting you or protecting somebody else because generally there's just too much flow of air through a gaiter. So you can look at different masks having different levels of efficacy. For those who are members of our practice, we sent out some masks a couple months ago. It wasn't an N95, it was called a KN95, which is almost as good as an N95, and a couple surgical masks, which are pretty good. And then a lot of people wear cloth masks, and those are fine. The only thing I encourage people is if you're wearing a cloth mask, you want it to be snug enough where you're actually breathing through the fabric. If the air is coming around, if it's loose and it's sort of coming around, and that's where virus can leak out the sides and in from the sides. So you want to feel like you're breathing actually through the fabric, because it's that fabric that's filtering the virus. So wear a mask, particularly if you're going to be in an enclosed space, particularly if you're going to be around people who you don't know, who potentially could be super spreaders, like the lawyer from New York. I think any more questions? Does anybody have any other questions? Please put them in. About that. I don't know the answer to this. Are there any other treatments on the horizon that you know of, Dan? Like there's this, the monoclonal antibody is the one that I've heard.
Yeah, it was a monoclonal antibody, but I have not heard of other treatments. I mean, I know that convalescent plasma is still being used under compassionate use, but I don't know of any novel therapeutics that we haven't talked about yet. Yeah.
So the president, when he was in the hospital, so he got the remdesivir, he got the antibody treatment from Regeneron. He got a medication called Pepcid or famotidine, and there may be some research that famotidine, which is like an antacid for your stomach, at pretty high doses, like way higher than what we would use for stomach acid. So, so he was given that. So there's some research that could be beneficial. And then from a medication standpoint, as you know, he got steroids. He got dexamethasone, and as Dr. Dan mentioned, the steroids are generally used in really sick people who are having this really dramatic immune response, and that so he must have been pretty sick, because if you give steroids early in the course where you're not super sick, the research suggested that is harmful to people, not helpful. So he must have been pretty sick to get that. And then there's some immune boosters that we talked about way at the beginning of the pandemic in March. So vitamin D, vitamin C, and zinc. So I'm not going to go into the dosing, but you want to be a little careful with zinc and too much zinc. Oh, that just answered Lori's question. So vitamin D, vitamin C, and zinc are probably the three that have been used the most. Can't say there's a lot of research, but have been used the most. And there's a question about the holiday season and travel. I think those are two different questions. So travel, Dan, have you looked into airline travel and sort of what the current thinking is with regard to infection and getting infected on planes?
I haven't seen it. So I know that some of the airlines are testing, or they're going to be offering testing, but I don't know of any data in terms of the safety of air travel. I think what we tell our patients, or what I've been telling my patients, is if you're going to get on an airplane, you're going to wear an N95 or a KN95, and you're going to wear it from the moment you step into the airport to the moment you leave the airport at your destination. You're not going to eat anything on the plane. You're going to wear either big sunglasses or some form of protection for your eyes. And I tell people, if they get in the airplane, to turn on the little jet of air and have it come down on them, because we at least know that that's filtered. And it may disperse droplets or aerosolized virus if it's in their vicinity. But no, I don't know anything about the safety of air travel at this point.
Yeah, I think I saw that maybe there have been a couple of cases of people potentially getting it from another traveler, but Dan, that's exactly the recommendations I give for airplane travel. KN95 or N95 mask. The moment you enter the airport, you might need to briefly sort of pull it down through the TSA check so they prove who you are. But then, you might be thirsty, but when you pull that mask down to get a drink of water, then potentially you're exposed to folks. For people who are flying business class, the addition, I say the final seat in business class, so you don't have anybody behind you, because the people behind you are the ones that could cough or sneeze or breathe over your shoulder. So if you have nobody behind you, in coach, if you're all the way in the back, typically that's where people congregate around the bathroom or the galley. I wouldn't want to be hanging out back there. And the final piece, which, is just hand cleanser. We sent out those little bottles of hand sanitizer. I think they're even allowing a full 8-ounce bottle of hand sanitizer in your travel, but I don't want you to have it thrown away. Check with your airline. But I think they're allowing even bigger bottles in your carry-on bags. And then with regard to the holidays. So this is the second time today somebody asked me this question. So I think we're going to get together as a team and talk about the holidays. I think, antigen testing is the way, if we were able to, in the few days prior to coming to an event, if all of your family members were able to easily and cheaply and efficiently test for the presence of the virus, then you might be able to create a relatively safe communal environment with people that you love. There is a test like that called the Abbott Binax Now test. The federal government bought all 120 million doses of that tests. I'm not sure what they're going to do with them, how they're going to distribute them, but I don't think they're going to be sold at Walgreens in packs of 10. So if there's one, there's likely others in development that are going to be cheap, easy to do at home, as if you're brushing your teeth. There is one, like I put in my most recent summary, I think the end of September summary. It's from India, and it's almost like a paper strip that gives, you put your swab sample on this piece of paper and you put a drop of liquid, and it's like a pregnancy test. It either gives a blue line or doesn't. And that's a whole new way of looking at using genes and stuff like that to look for the virus. So that was like $5, So maybe as we get a little closer to Thanksgiving, we'll have a better answer. And I think as we get closer, that's when we might put out a post. But where things are now, Dan, I don't know if you agree with me, without testing, you're taking a risk unless you all quarantine for 2 weeks prior to coming together. Since we don't really have good, efficient ways of testing, unless everybody gets tested, there's a chance that somebody who comes to your gathering will have COVID-19. I guess it really does also depend on where people are coming from and the community prevalence in the communities where people are living. So if there's no COVID-19 in your community or extremely low, maybe you could have a gathering, but that's certainly not the case for the Chicago area.
No, I agree with that 100%. I mean, I think you can't eliminate the possibility. And I think just my own family, right? My in-laws, my parents, I would feel absolutely terrible if one of them got infected from Thanksgiving, say. So it's all about, estimating risk and whether or not you want to accept that risk.